Now in Better Health, we celebrate staff, innovation, passion and commitment with the Southern Innovation Challenge.
So we basically do life support and maintenance of vital organ functions. So we deal with those people who are otherwise going to die unless we can keep them alive through this temporary period, and often with machines and drugs, whilst they otherwise heal the primary problem. Yeah, we saw the need and recognition of a growing body of literature that said that handover was a real danger time, that information gets lost and jobs get missed, because especially paradoxically in the really ill patients, there's so much going on that when it's handed over from one to another, the chance of missing something is higher. But this is the patient group who can afford to have something missed the least.
I'm an internal developer, so a software developer. So I worked with Matt and the others, Gordon, to help them see their vision by developing a system in-house. We've looked outside initially and there wasn't a great deal available, so we were able to help out by building something and meet their requirements.
This was something that was already in the middle of build when we won the money, and the build has been able to facilitate a whole bunch of other stuff. Well, we've used it for a couple of components. We, as you know, build this database component. Now, part of the database, what it does is facilitates handover between teams. So from the medical point of view, it facilitates handover from one doctor to the other. And the major advantage of that is that people can actually log on from home and they'll know what is going on in the unit before they come in. So it improves retention of the information for the doctor coming on when they then hear about it as well. And that's proved very popular. We've also built a handover component for the nursing staff, and what we find is that nursing staff here hand over to the nursing staff on the ward about a complex patient with lots of things going on. And so they now take a checklist piece of paper with them that the database has generated, and it says what is happening and what needs to happen in the future for this patient. So the nurses have a clear idea of what needs to happen. And of course there's also a printed note for the doctors on the wards as well.
To a certain degree, you've got to figure out what they do. I suppose your job is to try and ask them the right questions to try and establish what they do and what data they want to capture. But to say I understand all the medical data that they captured, it's probably not true, but enough to be able to get the requirements to meet the requirements, and then of course they validate and check it all.
So the first thing is that everything that could be automated is automated. In the old system, we had ICU nurses who were spending up to an hour of each patient they were caring for or more entering data on a computer. Now, this was data that was already on the system, it just wasn't on the ICU system. And so that was taking them away from clinical care, and so we automated all that. And it puts the nurses back in clinical care role.
Our principal goal is to, I suppose one of the advantages is we designed this to work for this particular ICU and Southland, our other site, but it's our principal aim to meet their requirements, not so much a generic tool, but one for them.
I can tell you that there have already been at least 4 other ICUs that have said, can we have it please? And so increasingly we're finding ourselves being asked if it is possible to build it. It's just a case of hours and time and logistics. But 10,000's been enough to purchase some of the equipment. A lot of the man hours are done, I think, by myself and other individuals who are really passionate about making this happen, want to do the best we can for our patients and do our best to improve outcomes for our critically ill people.
Some great innovation there and some people that show a real passion to providing quality service to patients.